Welcome everyone to Kidney Cancer Canada's Kidney Cancer Treatment News. This is a special national webinar that we're hosting this evening. I'm Stephen Andrew, the Executive Director of Kidney Cancer Canada, and I'm coming to you live from Victoria, British Columbia tonight. I'm not only an Executive Director here at Kidney Cancer Canada, I'm also a patient. I was diagnosed in 2006 with metastatic disease, and after a couple of surgeries and I went on oral therapy, my cancer started to shrink. And so today I'm happy to say that I am now 6 years, no evidence of the disease, and I'm not on oral therapy. So let's talk a little bit about what's going to be happening tonight. And I'm just trying to find my first slide. There we go. So we're going to give you an overview of what will happen. There'll be a brief introduction about Kidney Cancer Canada. We will then have the panelist presentations. We'll have some questions and answers, and then there'll be a brief wrap-up. So let's talk a bit about Kidney Cancer Canada. Well, we're a national organization, a community of patients, caregivers, and health professionals who work to provide every Canadian who is touched by kidney cancer with the support, education, and advocacy for their care pathways and treatment options. We do that through peer support. We have person-to-person peer support. We'll give you a contact number that you can call a little bit later in the program so that you can see that. And the other thing we have is an online peer support program, and that is through our forum, which you can find at kidneycancercanada.ca. We also provide information. We do this through our website. We also have publications and patient and caregiver forums, and we do advocacy. We believe that every kidney cancer patient deserves access to quality treatments. We teach patients how to advocate for their personal needs and to make their voices heard in the healthcare system. We also advocate with government across Canada, and you will see through the CanCertainty program that we are involved with, and actually we help lead. Nova Scotia made a significant change today in their budget to take home cancer drugs. Research, we helped establish the Kidney Cancer Research Network of Canada, and that's a Canada-wide collaboration of doctors and researchers, and it's answering key questions about the causes and best ways to treat kidney cancer. Excuse me, I have a bit of a cold today, as you can probably hear. Okay. Now, you can get more information on Kidney Cancer Canada simply by downloading the About Kidney Cancer Canada PDF, which you will find located under the handouts to the right of your screen. You can just have a look at that. So, that's enough about us. We'd like to know a little bit about who you are. And so we have a couple of polling questions, and you can answer the polling questions by, please, just clicking on the screen when you see the questions come up. Okay, I just have to close one other thing down. I do apologize. All right, here is our first question. We'd like to know who you are. Are you a patient, caregiver, family friend, or healthcare professional? If you could vote now, that would be great. Just a couple more people going to be voting. Takes a little while, obviously, when everyone's across the country. It takes a little while. Not everyone has voted yet. Nearly done. Terrific. This actually helps us with our programs when you can identify who you are, because that will allow us to tailor our responses today. Okay, I'm going to close the poll, and I'm going to share that answer with you, because as you can see, most of you are patients. We have some caregivers on the line. Family and friend are on the line, and we have a couple of researchers. Great. The next question we have for you is, where are you located? Are you in Canada, the United States, France, or another country? If you could answer that now, that would be a great help, please. Oh, that's terrific. Well, not a big surprise, but obviously most of you are from from Canada, which is a great help. And now, obviously, those that are in Canada, could you tell us, please, where you are located? Wait for the slide to come up that best represents you. Are you in British Columbia, Alberta, Saskatchewan, Manitoba, or Ontario? Going to close the polling in about 5 seconds. Okay, time is up there. Next poll we're going to give you is in what province do you live in? Obviously, Quebec, New Brunswick, Nova Scotia, Prince Edward Island, Newfoundland, and Labrador. Localized, obviously, meaning just in the kidney. Metastasized is in the kidney in another location, or don't know. This is going to be very valuable to our clinicians that are talking today, Dr. Kapoor and Dr. Kollmannsberger. They will know basically where our audience is. Terrific. I'm going to close that poll right now, and I'm just going to show that for our doctors so that they can see the numbers today. So we've got 60% localized, 67% it's metastasized, and 16% don't know. And of course, that don't know may mean that they've had a diagnosis, and it's possible that they haven't received all of the answers yet. Okay. Next question for you. It's about your surgery. What surgery did or will you undergo to treat your kidney cancer? Will you have a partial nephrectomy, or did you have a partial nephrectomy? Is it a radical nephrectomy where your entire kidney was taken out? Are you on active surveillance? That means they've spotted something in your kidney and they're just going to watch it for the time being? Or is it you don't know? We're going to close this poll shortly. A lot of people still voting. I thank you for doing this because this is really valuable information for us tonight. Okay, we'll leave it there. I'm going to close the poll, and I'm just going to share that for our clinicians today. So obviously 14% partial nephrectomy, 67% radical nephrectomy, 6% active surveillance, and 14% don't know. Next question for you. Actually, we will leave it right there. How's about that? That's a good opportunity. Thank you very much. Okay, we're now going to be joined by Dr. Anil Kapoor. And Dr. Kapoor is going to turn his camera and his microphone on now so we can see him. And he is joining us today from Hamilton, Ontario. I don't see you yet there, Dr. Kapoor. Maybe.
Can you see me now?
I cannot see you at the moment.
I can see me.
Oh, you can? Okay. Well, I'm just going to let you go to it then. Thank you. Thank you for joining us.
Okay. Well, I hope everybody can see my slides. That's more important than what I look like. But it's been a pleasure being here and giving you some up-to-date information on localized kidney cancer and locally advanced kidney cancer. And I'm joined by my esteemed friend and colleague for many years, Dr. Christian Kollmannsberger. So we look forward to a great dialogue and your questions. So I have about 19 slides. We said we'd keep it very concise to 10 minutes or so. So I'll start with my next slide. Do I advance my own slides? These are my disclosures. Right, next slide. Super. So the localized kidney cancer has been an evolution in surgical techniques. When you have localized cancer, the best cure is surgery, and we have very high cure rates for early stage kidney cancer. So in the 1970s, the standard of care was a radical nephrectomy, where you would just take out the entire kidney, and you had a spare kidney on the other side, and that was the standard for 20, 30 years or longer. Then in the 1980s, we did do some research knowing that if you do a partial nephrectomy and just take out the tumor and save the rest of the kidney, as long as the margin of that tumor excision is negative, that's as good a cure rate, if not better, than with a radical nephrectomy. So that's become the standard for localized kidney cancer if you can do a partial nephrectomy. Now, not all patients can have a partial nephrectomy. Sometimes a tumor may be too central, maybe too large, such that it's not possible. So again, I would ask your surgeon whether a partial nephrectomy is possible. If they say it's not possible, ask why it's not possible, and they should be able to explain it to you. And if that's not to your satisfaction, I would encourage a second opinion. In my practice, if patients want a second opinion, I encourage that, because it's your body, it's your tumor, and you want this excised properly the first time. And always get a second opinion if you're concerned about the surgery, and your surgeon shouldn't mind that if they're doing the right thing. And then in the 1990s, now we do this with laparoscopic techniques. So now we use robotic surgery, laparoscopic surgery. These are keyhole surgeries that we can do, so there's less morbidity and less time to recovery from these surgeries now. And then at the very last of the screen there, you can see that we now have what's called cryoablation. I'm not sure if you can see my pointer or not. Cryoablation, or RFA. And these are techniques that, great, thank you, somebody's doing that, so that's great. Cryoablation and RFA are great options to burn off the tumor or freeze off the tumor. And the cure rates of this minimally invasive technique are also very, very high. So these are new technologies that are now been around for 10 years that have become very, very good options for patients where surgery may not be possible. On the top here it says notes and simple port surgery. These are basically natural orifice surgeries where you can sometimes do these surgeries with no incisions, and that's another option for smaller tumors as well. So as we move through the spectrum of surgery, it's now much less invasive than it used to be. Next slide. So when you have localized cancer, again, the recurrence rates are dependent on the stage and the stage of the tumor and the grade of the tumor. So that's important information for you to ask your urologist or your oncologist. How big was your tumor? And what was the grade of the tumor? How aggressive were the cells are? And these two pieces of information can give you some idea about your risk for cancer reoccurrence. Next slide. Next slide. That's it. So this is hard to read, I think, but this is called the University of California staging system. And this gives an idea to our patients about what the risk of reoccurrence is. And the good news is that if you have a localized tumor, the very high, the very top of the line here, low risk, the cure rate is very high. So if you have a tumor that's less than 7 centimeters or even 7 to 10 centimeters, the cure rate is in the 80 to 90 to 95% range. when you have a small tumor, it's very rare that you have reoccurrences. And so that's really good news for our patients, is that if you have a localized tumor, the cure rates are exceedingly high. Now, if it's more advanced, in the middle here called high-risk tumor, these are tumors that are T3 or T4. That means they're into the renal vein or into the organs around it. Our cure rates are about 50 to 60%, still very, very high, but not as high as if it was in an earlier stage or grade. Next slide. So I'm going to talk briefly about just two trials that are new information for you. And a lot of patients ask, is there anything they can take after these surgeries, if they're at high risk for recurrence, to decrease the risk of the cancer coming back? So the first two trials were negative trials. These were randomized trials comparing sunitinib, which is a tyrosine kinase inhibitor, versus sorafenib versus placebo. And these are oral pills that you can take that many of you in the audience probably have heard about. And this was a negative trial, showing that there was no advantage. The STRAC trial was adjuvant sunitinib. This is released about 9 months ago or so, showing that if patients took some sunitinib for about a year afterwards, they had some advantage in terms of the disease-free survival. That means the time for the cancer to come back was prolonged. And so that was very promising. And then there was a PROTECT trial, which was released just a few weeks ago in ESMO, showing that there was not a lot of advantage to pazopanib in the adjuvant setting. Adjuvant means, again, after surgery, taking a drug to potentially increase your cure rate long term. Next slide. So this is the ASSURE trial. This was patients with intermediate and high-risk tumors. That means tumors that were 7 centimeters or bigger and higher grade tumors. And they were randomized to sunitinib, sorafenib, or placebo. Next slide. And these were disappointingly showing no difference. Surprisingly, placebo actually did better than sorafenib or sunitinib. That means if you took a sugar pill and not the real drug, these patients actually lived a little bit longer. So this is very surprising, saying that if you did have a big tumor and you had your cancer removed, then perhaps taking these drugs didn't help you afterwards. Next slide. This is the updated trial called the STRAC trial, a similar format, but a little bit of a higher risk population. You can see that this is a T3, T4. These are bigger tumors into the renal vein, and these patients were randomized to sunitinib and placebo. Many of you in the audience may have been part of these trials, and we thank you for your participation. And this trial was a positive trial. Next slide. Well, this shows that at follow-up of about 5 years, patients who took this drug, sunitinib, for a year after their surgery actually had increase in their disease-free survival. So they actually had a delay in the onset of any recurrent cancer after the surgery. So this is very promising. Now the asterisk or the caveat for this is that we don't know if somebody who took this drug would live longer than if they didn't. So we don't have an overall survival, but it looks like they may be about the same. But the advantage of this is that it may delay the onset or the reoccurrence of the cancer in patients who take this for a year after surgery. Next slide. So one study showed disease-free survival advantage, but not an overall survival as yet, and the other trials were negative. And the PROTECT trial, the pazopanib trial, was again not as high risk. Next slide. So the conclusion for this new data that came out just a few weeks ago is that you should have a discussion with your oncologist. So if you've had your surgery and it is a more advanced stage or grade, so you should ask what those are for your surgeon, your urologist. Say, what was the stage of my cancer and what was the grade of my cancer? And if it was a higher stage and grade, then you should talk to an oncologist about whether adjuvant therapy is right for you. Some patients feel this is the right thing for them, and other patients say, well, we don't have strong data as yet about survival, and even though it delays the onset of the cancer coming back, some patients may not want to do this, and other patients say they might want to. So that's where a discussion with a kidney cancer oncologist, and we have those on the KCC website who we can send you to in your region. Again, KCC is a great resource to find out where you may want to go for an opinion about an oncologist about this potential therapy. Next slide. No, the other thing that's new is about surgery. So we do know that if you have a metastatic cancer and many of you in the audience have this, taking the kidney out by a urologist who's experienced with these kind of surgeries helps you respond to your drug afterwards. So we do recommend, if it's possible, to take the kidney out, and then you will hopefully and most likely respond better to any sunitinib or pazopanib or any other drug clinical trial afterwards. Next slide. So the new data that came out was two trials, the Carmina trial and the ORTC trial. These were randomized trials to see, does this really help us in a prospective manner? And again, for patients that were in Canada in these trials, we thank you for your participation. We now have some results to share with you from these trials. Next slide. And this was the trial that was released last week. Dr. Jewett and Dr. Laurie Wood from Halifax were both co-investigators in this trial. Next slide. And basically, these were patients that were randomized to Sutent or sunitinib before surgery versus surgery and then sunitinib afterwards. So right now, when you come to see me in my clinic, some patients, we say, well, let's do sunitinib first and then do surgery later. And some other patients, we say, let's get the kidney out and then do surgery, then do the sunitinib afterwards. Which one is the right way? Well, this was a trial to look at which one would be better. Next slide. And what it showed was that, unfortunately, it was a poor recruiting trial. They didn't get as many patients as they wanted into the trial. So the results were provocative and basically suggested that perhaps if you delayed the surgery and went on sunitinib for a few months before surgery, you may do better than if you went to surgery up front. So this is, again, very provocative. It's not standard of care at all. Right now, the recommendation is to get your kidney out first and then go on a TKI, such as Sutent or pazopanib. But it's not wrong to go on a drug first and then have a delayed surgery. In fact, it may be better. So this trial was underpowered, but looks very promising. Next slide. So in conclusion, maybe just press on that a few more times. A few more times, that's it. So what it shows is that this trial didn't recruit very well because patients really wanted to get their kidney out and didn't want to go into this trial. But it does look like there may be an advantage to pre-surgical sunitinib or pazopanib, that last line there, that's maybe a good idea to shrink the tumor and maybe make it easier for the surgery afterwards. Next slide. That's more of the same. So this is my last slide. We have an organization called Kidney Cancer Research Network of Canada, KCRNC. And this is basically the research arm of Kidney Cancer Canada. And all the medical oncologists across the country, the key ones that treat kidney cancer, including Dr. Kollmannsberger and Dr. Riom, who is the lead author of this, put together a guideline for our patients about how to treat it. And this will be published this month, actually, or October, in a few weeks, in the CUAJ. It'll be available online. And just briefly, if you have come through the door with metastatic cancer, we recommend sunitinib or pazopanib, or consideration for clinical trial. And if those drugs don't work, the next options after that would include the middle bar, nivolumab, axitinib, cabozantinib, or everolimus. And if you progress on that, then we have options for the ones you haven't tried, which would be nivolumab or cabozantinib. And Dr. Kollmannsberger is going to talk about the data with cabozantinib and some new clinical trial data that's very, very promising. So I want to thank you for your time. I tried to keep to 10 minutes, and we look forward to your questions. You can always Twitter me at Anil Kapoor MD if you want to ask a question. I'd be glad to answer it. Or you can just call me on my cell phone, 905-407-0072. And if I don't answer, I'll call you back. Thank you.
Wow. Thank you, Dr. Kapoor. Really appreciate that. What we're going to do now is switch. Sorry, I'm just having a bit of a hard time with the... thank you. Okay, coming up now is Dr. Christian Kollmannsberger. I'm going to get him to turn his camera and mic on. And he's joining us from Vancouver, British Columbia, from the BC Cancer Center. There he is. Hello, Dr. Kollmannsberger.
Hello, everybody. Thank you very much for the invitation. I hope everybody can hear me. So I was asked to talk today about what is on the horizon for our kidney cancer patients in Canada. And what I would like to do in the next 10 minutes is to give you a very brief overview over a couple of important points when we talk about treatment for metastatic disease and then briefly talk about 2 new clinical trials and treatment options which are hopefully coming to Canada and Canadian patients within the next 6 to 12 months. Next slide, please. Those are my disclosures. Next slide, please. So I just would like to quickly talk about a little bit about what the available treatment options are and how we see them. We just talked about surgery. I don't really want to go into that. When it comes to the treatment of patients where the tumor has spread, we have a number of treatment options. One treatment option which is often overlooked is observation, and you may be surprised sometimes when your doctor says, you know, we don't need to really do something immediately. And that is because kidney cancer is a very variable disease. Some patients have very fast-growing tumors, and some patients have tumors which don't really do much over years. And there is no recipe how to identify whether you are one of those patients or not. But your oncologist, if you have a stable situation, may opt for just simply repeating a CT scan in 2 or 3 months and to see how your tumor behaves, and then potentially asks you to simply stay on observation. I have patients who have been on years on observation, and the good thing about it is you can avoid the side effects of treatment, and studies have shown that this is not detrimental if you go on observation. Radiation therapy is used mainly if you have local problems, such as with bone metastasis or brain metastasis. And then we have the chemotherapy part, or as we refer to as systemic therapy, because what we do with kidney cancer patients these days is not really classic chemotherapy as we know it from other tumor types. What we use is targeted agents, and now new in the collection of drugs we have is immunotherapy. Next slide, please. What are those things? So targeted agents, they're called targeted agents because they interfere, usually inhibit, a specific mechanisms in or around the tumor, which is crucial for the tumor to grow and to spread and to cause problems. Immunotherapy is a form of biologic therapy. What we are trying to do is we're trying to reactivate the immune system to fight your cancer. Obviously, every person on this earth at some point in his life or her life develops cancerous cells. What happens is the immune system recognizes them, gets rid of them, and you don't develop cancer. Obviously, if we develop cancer, then something has gone wrong with that part of the immune system. And over the last 10, 20 years, we have learned a lot how that happens. And now we are seeing the first drugs coming which try to reactivate the immune system to fight your cancer, and that seems to be very promising for a variety of different cancers, including kidney cancer. Next treatment. Next slide, thank you. What are we trying to do? And I just would like to give you a brief background on the terminology doctors usually use, because I think it's important to understand what's behind that. So what we are trying to do with our treatment is we want to shrink tumors. That's what we usually refer to as response rate. We want to prolong the interval where your tumor is stable or doesn't grow. That's usually referred to as progression-free survival. And of course, we want to extend the lifespan. That is usually what we call overall survival. And then ideally, we would like to cure patients. That's what we often call long-term remission or lasting complete remission. It is important to recognize that when doctors and oncologists talk about progression-free survival and overall survival, they usually talk about what we call median progression-free survival or median overall survival. And that is something which you have to keep in mind, because all these data are derived from studies, which means they apply to a large number of patients. And the word median means that 50% of patients may live as long and 50% may live longer. But we are never able for an individual patient to determine how long a patient will or will not remain progression-free or will survive, because the width where patients can be on that curve is very, very variable. So that just a little bit as a background when we talk about clinical trial result. Next slide, please. So this is a brief overview of what is available in Canada. So for first-line use, that means for patients who have metastatic disease but have never been treated for it with targeted agents or immunotherapy, right now we have sunitinib, we have pazopanib, and an old drug which is called sorafenib. If that doesn't work, then we can move to second line. So the line of therapy after a patient had failed one line of therapy, we have axitinib. We have a drug called everolimus, and we have a new drug called nivolumab. And brand new since March of this year, most provinces should have that by now, we can give something in third line, and that is nivolumab, if patients previously have been treated with 2 NIPs. So usually sunitinib or pazopanib, and then axitinib. Next slide, please. Now, ideally, as you can see, we have options, and your physicians have options. And the question is, well, how do they select that? Ideally, what we would like to have is, we would like to be able to measure something in a patient, in the tumor, some characteristic, which would tell us, yes, this patient most likely will benefit from drug A or drug B or drug C. That is what we call a predictive marker, which tells us which treatment is best for that patient. Unfortunately, next slide, please, we don't have that yet. So your physician, your oncologist will probably make the choice of what drug he wants to use based on your personal situation, because these drugs have slightly differing side effect profiles, what other drugs you may take, whether you have any pre-existing other health problems, and I think most importantly, your oncologist will probably choose a drug he is very familiar with, because it is extremely important that as a physician, I know how to manage a drug and a patient so that the patient can get the maximum benefit from that drug. So let's move to what is on the horizon right now. And one of the 2 drugs or 2 treatment options I would like to discuss today is a drug called cabozantinib. Cabozantinib is, again, as you can probably say, it ends in NIP. All these NIPs, sorafenib, axitinib, sunitinib, pazopanib, cabozantinib, they come as pills. They are so-called tyrosine kinase inhibitors because they block a certain mechanism in the tumor cells. And as all the other NIPs, cabozantinib is usually given continuously as a long-term therapy, as a daily pill. It's usually able to do that as an outpatient, as with the other NIPs as well. But the treatment needs surveillance because, as all the other drugs, cabozantinib also can have side effects. Next slide, please. And the study which was done with cabozantinib was a study which recruited patients who previously had failed 1 or 2 prior or more therapies, but patients had to have treatment previously with 1 or 2 tyrosine kinase inhibitors, so either sunitinib or pazopanib, or sunitinib, pazopanib, and axitinib. And they were and this study looked at cabozantinib versus the drug everolimus, which I talked about previously. That was considered the standard of care at that time when this study started for patients who previously had failed a line of therapy. Next slide, please. So about 70% of patients in that study had 1 prior line of therapy, and about 30% of patients had 2 or more lines of therapy. And that is important, and we'll talk about that a little bit later. But this is important to look at for us and for Kidney Cancer Canada, because when it comes to how should this drug be used in Canada, we usually have to adhere to the patient profiles which were recruited for that particular study. Now, what was the outcome of that study? Cabozantinib showed to be superior in tumor shrinkage rate, so it had an improved response rate. It meaningfully improved the tumor growth-free interval, so the progression-free survival, which means patients who took the drug stayed progression-free longer than the patients on everolimus, and it also meaningfully extended the overall survival, so patients lived longer on that study. Cabozantinib was reasonably well tolerated, but it does have a number of side effects. Next slide, please. And those side effects include more tiredness, elevated blood pressure, a sore mouth, indigestion, diarrhea, skin rash, hand-foot syndrome, so the painful blisters on hands and feet. And all of you who have been treated with a tyrosine kinase inhibitor will say, well, that's exactly what my tyrosine kinase inhibitor can do as well. And that is true. They have a very comparable side effect profile, all these TKIs, with some variation in there. It's important to realize that side effects can happen, they don't have to happen. And just because you had some side effects on one tyrosine kinase inhibitor doesn't usually not mean that you have to have them on other tyrosine kinase inhibitor as well. But it is important that these treatments with these drugs are carefully monitored so that we can stay on top of any side effects and make adjustments to the treatment as necessary. Next slide, please. The other, and this is brand new, this literally came out about 2 weeks ago. And this was a study which was presented at the European Oncology meeting, and that was a combination of the drug nivolumab, which we already have in Canada for the treatment of patients who previously have failed 1 or 2 tyrosine kinase inhibitors, plus a drug called ipilimumab. Ipilimumab is a drug which also has been in the market for a while for the treatment of skin cancer. They are both called so-called checkpoint inhibitors, and we get to that, what that exactly means in a second. This is treatment which is also continuously given as long-term therapy, but these are infusions. They are no pills. They are infusions which are usually given every 3 weeks for about 3 months, both drugs, and then the treatment continues with the nivolumab drug alone every 2 weeks. So if patients get that, they will have to come for infusions every 2 weeks. That can usually be given as outpatients. You don't have to be admitted. You don't have to be in hospital for that. And again, there is a number of side effects which I briefly would like to discuss with you so that you have a little bit of an idea of what these things do. Now, what are these things doing? These are drugs which are called immunotherapy. So what is the background? How do they work? So the immune system usually can tell between normal cells in the body and those which they see as foreign. So any cells, cancer cells or other cells which shouldn't be there and can potentially cause a patient to become sick. And the immune system is built in a way that it can attack the foreign cells while leaving the normal cells alone. And the immune system uses certain checkpoints, and that's where the name checkpoint inhibitor comes from. Those are certain molecules, certain mechanisms which need to be activated by the immune system in order to start an immune response and fight a cancer. And what we found over the last 10, 20 years is that cancer cells, which are really smart, they found ways to use these checkpoints to avoid being attacked by the immune system. So they basically use these checkpoints to signal to the immune system, we are part of the body, do not attack us. And then in an environment like that, cancer can grow. Next slide, please. So as I said, both of these drugs are so-called checkpoint inhibitors. Just for the background, nivolumab targets a checkpoint which is called PD-1, programmed death receptor 1, and ipilimumab targets a which is called CTLA-4. And both of those, PD-1 and CTLA-4, are checkpoint proteins on immune cells called T cells. T cells are one of the most integral and important parts of the immune system and the cascade to start an immune reaction. In the normal functioning immune system, both act as type of an off switch. So when an immune reaction starts, you want to make sure that the immune reaction is not overshooting, because that could be harmful as well. So while the immune system is turned on, this immune system, smart as it is, it also turns on mechanisms to limit the immune response so that you don't get any trouble from an overshooting immune response. So when we use these drugs, what we basically do is we boost the immune response against cancer cells. We interrupt that signaling from the tumor to the immune system, saying that I'm part of the body, do not interrupt us. So we make the tumor visible again to the immune system, and the tumor can, the immune system can subsequently attack. And that has been shown to be very helpful in a number of tumor types now, including skin cancer, even lung cancer, bladder cancer, and also kidney cancer. And nivolumab was the first drug which was approved and subsequently funded in Canada. Next slide, please. So this was a study in patients who previously had never been treated. So as what we call a first-line study, and that looked at sorry, next slide, please. That was a study which looked at, there's a mistake with the slide, that looked at the combination of nivolumab and ipilimumab versus versus sunitinib, with sunitinib being considered the standard as a first-line therapy. In order to be enrolled into that study, patients had to have certain risk factors. When we look at patients with metastatic disease, we know that not all patients will have the same outcome because there are certain factors which include outcome, and we can differentiate patients in three risk groups. And patients who had a number of risk factors and fell into the second and third risk group, they were allowed to be on that study, and those were the patients where this was tested. What were the results of this study? It turned out that the combination with this immunotherapy was superior to sunitinib in terms of tumor shrinkage rate, so in the response rate. The combination modestly improved the tumor growth-free interval, so the progression-free survival was longer with nivolumab ipilimumab, but it was modest. But nivolumab ipilimumab made patients meaningfully live longer, so the overall survival was improved, and that is always what we consider the most important point, because we want our patients to live as long as possible. And what is also important is that the combination made the tumor disappear completely in about 10% of patients, and that is something which we have not seen before with targeted agents. The number of patients where the tumor completely disappears with targeted agents is about 1 to 2%. And the combination was reasonably well tolerated, but it can have some side effects. What are these side effects? These drugs are usually quite well tolerated until they are not. And until they are not means because we take the brakes off the immune system, we can get overshooting immune system reactions. And that affects about 20% of patients. In up to 8% of patients, those were what we consider severe reactions. And what usually happens is if you have an overshooting reaction, then the immune system starts to attack cells which are supposed to be in the body. They can start to attack the bowel, and you get what we call a colitis, an inflammation of the bowel, which ends up in diarrhea. It can attack the liver, and you get a hepatitis-like picture. You can get a skin rash because the immune system reacts to your skin cells, and you get what we call dermatitis, and a variety of other inflammations in other organs. All of them end in itis when you take the medical term, and that is important to recognize, and that's why you have to learn about this if you get a treatment like that, because these side effects can potentially be very severe and even be lethal in a very small number of patients. However, if you recognize them early enough, then we usually can treat them and control them quite nicely. What about the availability of these drugs in Canada? Both of these treatment options are currently going through the regulatory process in Canada, which is a fairly lengthy process. They expected to have passed regulatory and pricing negotiations, which is an important part in Canada, within the next 6 to 12 months. The pricing, as always, will be an issue, and Kidney Cancer Canada will work hard to make these drugs available and to hopefully be able to raise the opinion and voice of the patients to the regulatory authorities. Cabozantinib will most likely be approved for patients who previously have failed 1 or 2 prior treatments, and nivolumab ipilimumab will be for patients with certain risk factors and no prior treatment. And I think it's important that we support organizations like Kidney Cancer Canada because they play an invaluable part in making sure that we can actually get these drugs for our patients. Thank you very much.
Thank you very much, Dr. Kollmannsberger. Appreciate it. Well, joining us now from Quebec is, we'll get her to turn her camera on. There we go. Hélène Veilleux. She's from Blainville, Quebec. Excuse me just 1 second. Patient perspective and, of course, patient and caregiver-centric information is very important to us at Kidney Cancer Canada. So whenever we do these forums, we always make sure that we have the patient perspective. And Hélène, I'm going to hand it over to you now. Good evening.
Thank you. Hi, everyone. I am currently a stage 4 kidney cancer patient. I'm a survivor. I've been diagnosed in 2008. So I've been a survivor for almost 9 years now. I'm currently on a second line of treatment. I'm on nivolumab. So I was diagnosed at 42. I had a radical nephrectomy of the right kidney. I was in a regional hospital near my house. And the urologist at that time said to me that I was early stage, and it was a clear cell kidney cancer type. Even though my tumor was 9 centimeters long. I was after surgery and my radical nephrectomy, I recuperated very well. I was back to work less than 3 months after, and with the okay of my surgeon, I was able even to go back to training. I was a very active person, formal athlete, but so I went back to shape as quick. It was so my first recurrence was in November 2012. We on a scan, a follow-up scan, it showed that on the right side, on my right side, in the surgical bed, there was small lesion from the diaphragm to the psoas. There was a biopsy made by my first urologist. He asked for a biopsy to be made, and it came back as a non-clear cell, kidney cancer cell. So this urologist felt comfortable by doing the surgery, but he had met a couple of weeks before. He had attended a seminar done by Simon Tanguay, who is a Uro-Oncologist at the McGill University Hospital Cancer Center here in Montreal. So I was referred to him, and the scan was made in I think it was October. Got their test result. There was other tests made, and I was not able to meet and have an appointment with Dr. Tanguay only in after all the Christmas holidays, and so it was in January 13 that I had my first appointment with him. He ordered some new tests. He even redone the pathology from the surgery of the nephrectomy that was done in 2009, and it came back that I was from the beginning a non-clear cell, and the type is a chromophobe. So at that meeting, prior to that meeting, there was a time period, a waiting time, and I felt really awful. I was very discouraged, and I decided to do some research about recurrency, and I needed some information, right, of seeing Dr. Tanguay. So I did some research, and I first found the Kidney Cancer Canada website, and there was a ton of good information, and I got reassured about all the information about treatments, that they were treatments, about patient testimonials, about important question to ask to your physician. So for me it was very important, and when I got my first appointment with Dr. Tanguay, I came prepared, and we had a lot of questions. So, and from the information we had on Kidney Cancer Canada website was not to be alone. And just a little example, I was impatient. I was an impatient patient at the time. I was eager to begin the treatment, and I was kind of frustrated about the new doctor ordering new tests. And for him, the scans that was done in prior to, at the other hospital was not clear enough for him. But I had kind of the feeling that he didn't want to take care of me, but my husband who was with me said, no, 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 we just want to make sure. And so it's so important not to be alone, and you receive a lot of information, you have lots of questions, so by being two with a caregiver, you make sure that every question you have is asked and well answered, and that you understand. And from that day, it's going to be almost 5 years now, I never re-questioned him. I always felt comfortable. I felt I was at the right place and in the right care. So from all the tests were done, and I began my first line of treatment. I began sunitinib for a period of 4 months. At the time, they had presented me plan A, plan B, plan C. We could do that. What do you want? And for me, I wanted the surgery. So it was decided that we would do treatment. I took sunitinib for 4 months at that time. It was the cycle. I took it for 4 months, 4 weeks on and 2 weeks off. So, and I had the resection. I had the surgery in 4 months later. On while he did the surgery, about the resection on the diaphragm, it was something particular. So they asked for a thoracic surgeon to be present, and the way the diaphragm, from what I've understand, is they were not able to take everything out. They took what they saw, they took what they felt, but there was a recurrency a couple of months after, more than 6 months after. There was little cells, little something on the diaphragm. So I went back on sunitinib for 6 months in 2014, but with a cycle of 2 weeks on, 1 week off. I would say that the main side effect was fatigue for me at the time, and it did with the change of the cycle with 2 weeks on and 1 week off, it helped a lot with the fatigue. It worked very, very well, and even just prior, the scan prior to my surgery was showing that there was no evidence of disease. The tumor, the lesion has shrunk a lot, and so they were able to do a resection. There was a little something on the liver that was always been a question, but they were never able to do a biopsy on it. So Dr. Taghi asked for a specialist of the liver to assist him on the surgery in 2014, and they took care of and it came back that there was some kidney cancer on my liver. So because of the way it was on the diaphragm, they've decided to go on in 2015. I had a consult in radio-oncology, and I had 20 treatments. No, it was not cyberknife. There were no evidence of cancer at the time. In 2015, scans were all clear, but just to make sure, they wanted to cover the area on the diaphragm that they could not take out. It was impossible to take more out, but I had 20 treatments. They took it not on the regular radio-oncology treatment. It was made on a certain way that new studies at the time showed that you could attack renal cancer cells, and it was to cover the region of the diaphragm and part of where the lesion on my liver was. And from, it seems, 2.5 years later, we can say that it was a good bet because there's no recurrence in this area. On that year, on a scan in, I think it was in the fall, it shows that there was a recurrence on my right lung. So I had surgery. I was referred to the same thoracic surgeon, and I had surgery that December for the small, very, very small cancer cell. In 2016, there was a recurrence in my liver, and also there was an ovarian cyst that was always clear on scan, but became solid. So there was a biopsy made, and there was kidney cancer in the cyst that I had on my ovary. So in May 2016 to May 2017, I was on Sutin for a year. I was on sunitinib for a year with a cycle of 2 weeks on, 1 week off. I stabled the lesions I had for a year, but in a scan in April 2017, this year, it showed the progression of the disease in my liver. So I've been on nivolumab treatments of every 2 weeks. I had just had my 10th treatment last Friday. And my energy is back after a year on sunitinib. It was my energy level was very low. I had all kinds of gastric problem, but I can say that I recovered very well. I have little fatigue. Sometimes I have to take an afternoon nap. But so I'm monitored every 2 weeks. I see my oncologist and we do blood tests, and so far I'm feeling very, very well. So I hope I was able to, with my testimony, I was able to answer maybe some question or reassure some of other patients that present.
Thank you, Hélène. Appreciate your story, and it does provide other patients with great information, by the way. All right, it's time for questions. So I'm going to call back our panel. We're going to ask you to please type your question into the chat window, and you'll find that located to the right of your screen. I believe the questions have been turned on. Get Dr. Kollmannsberger back as well. And while you're doing that, excuse me, our doctors have a couple of questions for you that they asked us to ask you, so we'll do that right now. And the first question that we have for you is, are you satisfied with your kidney cancer treatment? Yes or no?
Undecided.
Okay, the next question coming up at you. Have you considered a second opinion? Yes, no. Do you not want to offend your doctor, or are you undecided? There are your answers. 55% say yes, they have considered. 18% and 18% say no, and I don't want to offend my doctor. and 9% say they are undecided. Next question for you deals with clinical trials. Let's have a look at that. And it's coming up right now. Have you ever participated in a clinical trial? Yes or no? Or you don't know? And there are the responses. 25% say yes, 75% say no, and we have nobody that says don't know. Okay, next question for you. Again with clinical trials, and it deals with the treatment areas. Do you know about clinical trials? Do you know about any clinical trials in the area that you are being treated? Yes or no? Okay. There's the answer. 25, 1/4 of you don't know. So that's an interesting number to look at. Next question coming at you again with clinical trials, and that is regarding how do you know whether do you know that how a clinical trial could impact your treatment options? Yes, no, or don't know. Answers coming up. Yes, you do know about clinical trials, 38%. This is a disturbing number for us at Kidney Cancer Canada. 44% say no, and 19% say they don't know. I will tell you that there's a full list of clinical trials for kidney cancer on our website under clinical trials at kidneycancercanada.ca. Next question. Coming at you right now. Is that it?
No more questions for now, Stephen.
No more questions. Okay, great. So what we're going to do now is go to our questions. I will read them out. I've got them all here. There's a lot of questions coming in, so we will do it. Just type it into the chat bar, and we'll make sure that we get them. Our first question is from Vanessa. She says, I'm getting partial laparoscopic in a month. How is the recovery? I'll leave that to Dr. Kapoor.
Normally the recovery is about 4 to 6 weeks. It's still a big operation. It's still a 3-hour operation. Even though we do it with keyhole surgery, it's still taking out a chunk of your kidney and putting it back together again. It takes about 3 hours in the operating room. Hospitals stay 2 days. So it does take some time to recover for sure. Some people expect it to bounce back within a couple of days, and I wouldn't expect that. I plan to be off of work for about 4 to 6 weeks.
Okay, question from Jen. She says, is there a difference between, oh, sorry, I'm just going to skip that one. Has cabozantinib applied for Health Canada consideration for approval here? Before I pass that over to both of you doctors, because we are going to have a discussion on that, I can tell you that PCODA, which has asked for a submission from Kidney Cancer Canada on cabozantinib and whether we support cabozantinib going on to the provincial registries across the country. Obviously, it's another therapy, and we do. And I'm going to have a little bit of information at the end of the webinar on how you can actually help us to secure that drug for patients across Canada. So I'll start with Dr. Kollmannsberger.
Yes, cabozantinib, to my knowledge, has been submitted to the regulatory authorities. I think they have started that process. The process usually takes about 6 to 12 months to go through all the different regulatory panels until we then can hopefully have that drug. Now, some companies will make a drug like that available to patients before that in so-called expanded access programs or in special authority Health Canada programs, that is something you should talk to your doctor to. There are usually some conditions applicable to these programs, but definitely if you are in a situation where this drug may be beneficial for you, you should approach your oncologist and ask about that and see whether something like that is in place.
A question that we get a lot actually here at Kidney Cancer Canada is there a difference in treatment between Canada and the United States?
Well, I guess I can take that one on. I guess in general, many of these drugs are available in the U.S. first. For whatever reason, Health Canada may be a little bit slower to approve it, or maybe there's more regulatory red tape in Canada. But also, I think the companies that make these drugs sometimes do it after they get filed in the U.S. and then in Canada afterwards. So it would be nice to be simultaneous, but that's the reality of what we live in right now.
Can I just add something on here?
Absolutely.
Are there differences between the two countries? Yes. As you know, medicine in the U.S. is a business, and there's a number of important differences. In the U.S., depending on your insurance status, you can use all of the available drugs in whatever sequence you want. That is not so in most countries in the world, including Canada. So in Canada, the drugs are usually approved and tied to a certain patient situation, first line, second line, etc. And we cannot use these drugs as we think or want, one after the other. Usually in Canada, the placement of a drug in the treatment algorithm is based on the availability of data showing that the drug in that situation actually has benefit.
Next question for Dr. Kollmannsberger. Are there less side effects with nivolumab?
So there's a couple of things I think which are important. Number one, every drug can have side effects. Number two, we never can predict whether side effects happen or not, and every patient is different. Some patients will go through a treatment and say, well, this was it, there was nothing, and some patients will have significant problems. Now, I think in general you can say that nivolumab is a very well-tolerated drug compared to, for example, the tyrosine kinase inhibitors. So nivolumab in most patients is extremely well tolerated, but again, if you give nivolumab alone, there is probably 2 to 5% of patients where they who get these immune system related side effects where the immune system shows an overshooting reaction, and then these are side effects which can potentially be severe. So even so that most patients tolerate nivolumab quite well, it needs somebody needs to keep an eye on it.
Let's get Hélène to jump in here. You're on nivolumab, Hélène. Just talk a little about your experience with side effects.
Well, if I can make the difference from side effects I had on sunitinib, fatigue was, for me, was the big thing on sunitinib, especially the last 3 to 4 days of the 2-week cycle. From now, I'm full of energy, and sometimes I kid around and I said I'm like the Energizer bunny, the pink bunny. You know, I can do whatever I want. There's a big difference. No more digestive problem. I had acid reflux and sunitinib. I don't have had loss of appetite. My appetite is back to normal with nivolumab. No nausea, no vomiting. From what I experienced, nothing on my skin, no irritation, and no hands and feet syndrome. I have nothing. So there's a big difference from side effects I had with sunitinib, and now it's kind of on a vacation right now.
Oh, that's nice. Good. Dr. Kollmannsberger, perhaps you could, a question I got on the phone the other day was, I've gone on cabozantinib, but I've had absolutely no side effects. I'm concerned the drug isn't working because I was told if I don't have side effects, the drug isn't working.
That is a tricky question. So I don't think you can generally say that. We don't know that for cabozantinib. I think there is some general understanding that with all those tyrosine kinase inhibitors that dosing is an important point, and with sunitinib or the drug axitinib, we usually try to give a dose which causes mild side effects, because we have seen that in order for the drug to be most effective, there needs to be a certain level of the drug in the body, and the onset of side effects seems to signal that that level is good. That's why we are doing this. For cabozantinib, we have not seen any data like that. I would not be surprised if it is similar, but I think we need to look into that. We don't have enough experience with the drug. But the absence of side effect does not always say that it's not effective.
Okay. Dr. Kapoor, how do you decide to remove, biopsy, or surveil a tumor in the lung? That's from Randall.
Sorry, the question was again?
The question is, how do you decide whether to remove, biopsy, or surveillance of a tumor in the lung?
In the lung. Well, so that would presumably be metastatic disease from the kidney to the lung, and so you have a lung spot that's kidney cancer that's metastasized. So as Dr. Kollmannsberger was saying, we have lots of new data suggesting that if these lung nodules don't grow very quickly, you could just wait and watch them. And if as long as they grow very slowly, you could watch them for a long time. And I have a number of patients like that where they have lung spots that are growing very slowly. We don't need to do anything. We do know that even if you go on a drug afterwards, maybe a year later when they start to progress, you will still respond just as well as if you started now. So one thing is to do is just survey them if they're slow growing. And as Hélène's story would attest to, if you can remove a small spot in the lung, that's your best option to cure it, to get club, NED, or no evidence of disease, is to remove these spots. There's also new options with radiotherapy. You can do SBRT radiotherapy to these lung nodules. And there's also new technologies called RFA, where they put a needle inside the lung nodule and burn it off. And that's also very promising for isolated lung spots from kidney cancer to potentially cure them. So your best option is to remove it, or burn it, or radiate it, or just survey it. And if that all fails, then the next step would be going on a drug, such as sunitinib or pazopanib or a clinical trial, to treat these lung nodules.
Leads to another question, Dr. Kapoor. This is from Vicky. Why would a partial nephrectomy be chosen over ablation techniques?
So that's a great question. And so the issue with ablation techniques is that you put a needle inside the tumor in the kidney and you burn it off or you freeze it off. But the mass is still there. And we think the cells inside, or we pretty much know that the cells inside are dead. But the mass is still there, so you have to have long-term surveillance for the rest of your life after RFA or cryoablation. So we've been doing that more in some older patients, but I've been doing it, and many of my colleagues, in younger patients as well, but we don't know when to stop following. When you do surgery, we generally stop after a few years, 5 years, because the risk of the cancer coming back after 5 years is very unlikely. So the standard around the world right now is that if you have surgery, a partial nephrectomy for that cancer, you can stop worrying about it after 5 years and no further follow-up is required. With these new technologies, we don't know when to stop following. So right now, I follow them forever with a CAT scan or an MRI every year just to make sure those cells don't get reactivated after RFA or cryoablation.
Thank you, Dr. Kapoor. This question, I guess, is going to be for Dr. Kollmannsberger. It's from Deborah. Deborah asks, my husband has received 36 nivolumab treatments so far. Do we know how long he can stay on this drug? This is his 4th line of treatment.
So nivolumab is a drug which was developed as a treatment which should continue as long as the patient benefits. We have very little data to date what happens if a patient has a good response and we simply stop. There are trials underway and we are trying to get these data, but for the time being, nivolumab is designed so that patients are supposed to stay on it for as long as they benefit. And from the data we have so far, it seems that there are no longer-term effects or new toxicities coming when you take the drug for a long time. Of course, we haven't had that drug for that long, so there's a limit to that information. But in general, the patient seems to have a very good response to nivolumab because he has been on it for a very long time. And based on the available data, we would recommend the patient to stay on it.
Thank you. Another question on nivolumab is, is it possible to re-challenge with nivolumab after having a reaction? John says, I've been on nivolumab for 9 months with no side effects and stable disease, but had a severe reaction last January. I have been off treatment for 8 months, but now have some progression and must begin treatment again. Is nivolumab still an option?
So there's not much data on that at the present time. I think it depends what your oncologist is willing to try and what the severe reaction was and whether the reaction has completely resolved. I would discuss that with the patient based on those on the answer to those questions. I think generally the official recommendation is if you had a severe reaction to that drug, you should not re-challenge a patient. Whether that will change in the future, that remains to be seen. We don't have much information on patients who had re-challenged with that drug yet.
Thank you. Let's question for Hélène. Hélène, thank you for the patient perspective. It must take great courage to share your story. Good to hear that your new treatment is going well. Were you offered other options? What made you choose your current treatment?
Well, when in May 2016, when I heard there was a recurrence on my liver and part of the ovaries, I have heard that there was a trial, a clinical trial open in Montreal for nivolumab. I've read about it, and I wanted to experience that new drug, but because I was a non-clear cell patient, I was not able. The trial was not open. The clinical trial was not open to me. So I had in my mind, and I wanted to be able to if I could be able to be treated by and try that treatment. And so when it came, it was my oncologist wanted me to go on, and for sure for me, you know, it was I've been waiting for that for a year. Even though I know about the results, I know it's not every patient, it's not working for every patient. I know all the everything on it, but it was for me. I wanted to try this this new line of treatment.
Okay, thank you. This question, I'll open it to both doctors. How many small tumors can be removed from the lung, and what are the risks of removing them?
So I guess I can start that one first, and Christian can disagree as he always does. Just joking, he never disagrees. Usually it's up to 4. So that's very variable. Every patient is different, and we treat every patient individually, depends on where they are. If you have 4 spots in one lung, that or a part of a lung, we'd recommend that that piece of lung be removed and all 4 spots would be gone. If they're in different areas of the lung, then you can radiate or burn off up to 4 of them. That's generally what we do, but if there's 5 in one area of the lung, then we would do that. That's where we get, that's where it's important to get an opinion from a team of kidney cancer experts, a medical oncologist, a surgical oncologist, and radiation oncologist, and where we all sit together and decide what the best option is. Again, 4 is an artificial cutoff, but it's variable for every patient.
Yeah, surprisingly, I would agree with that. I think if you have more than 4 or 5, it begs the question whether you should have some kind of systemic treatment and make sure that the situation is stable before you go in and remove all those nodules. And that has been shown in data. I mean, So it is often an individual decision, and that's why I think what Dr. Kapoor said is extremely important, that you get an opinion of a team of kidney cancer experts which have experience with that and include radiation oncologists, surgeons, as well as medical oncologists.
Great, thank you. A couple of questions here that actually I think should be answered by you. Gina says, I see my oncologist annually now, but I'm very tired. I don't know whether to seek him out.
So you're very tired with localized disease or metastatic disease?
She doesn't say. She said she was in a clinical blind study of sorafenib versus sunitinib.
So probably in the
that's it
sounds
looks
like an adjuvant study.
Yeah.
Yeah, it sounds like it was an adjuvant study. Sounds like her cancer is all cured. The first thing I would do is go to your family doctor to rule out any other causes of being tired that are not cancer related. Could be thyroid, could be blood pressure, could be diabetes. All sorts of other things can happen. It's not always cancer related. And then if that's been ruled out, again, it sounds like a CAT scan would be helpful if you had a history of advanced kidney cancer. And if the CAT scan is clear, then you're golden. And if the CAT scan is not clear, then you need to see a medical oncologist for their opinion.
Okay, next question, Dr. Kollmannsberger. This is from Mike. What's the reason for discontinuing the IPI during the nivolumab-IPI combination?
That's a good question. There's a number of reasons why they did that. Number one, the ipilimumab adds quite a bit of toxicity, so side effects to that combination. And it appears that it is based on previous data that it may be enough to give that combination for a short period of time and then continue with one. So those are kind of reasons. At the end of the day, the question is very, very valuable because, you know, when you develop a drug, at some point you have to make a decision with what kind of mode of application you start. And then you do that trial and you do that and you choose that mode of application based on the best information you have. But it may well be that in the future we will see trials which look at different types of applications and different schedule how to do that. And maybe even trials where you give the ipilimumab in the beginning and then you continue with nivolumab, and if that shows that it doesn't work anymore, maybe it's beneficial to put the ipilimumab again together with the nivolumab. So future trials will hopefully clarify more whether that's the right way to do it or whether there's a better way.
Thank you, Dr. Kollmannsberger. Dr. Kapoor, what is the kidney function expectation after a partial nephrectomy?
So the main predictor of that is what your kidney function was before the surgery. So we don't expect your kidney function to change. Sorry, this dog just won't go away here. Let's try and get rid of it.
We are getting fan emails on the dog.
The kidney function it shouldn't change much at all because we just removed the tumor. So, well, the best operation to do is to remove the tumor with a 1 centimeter margin. That means just a rim of normal tissue around the tumor, so you know you got it all out, and then you know that that's the cancer is cured. So we don't usually take out much more than just the tumor.
Thank you. A question now. Let's give this to Dr. Kollmannsberger and both of you, actually, I guess. Would doctors help patients in Canada get into a U.S. trial if there was no trial available in Canada?
Generally, yes. If there is a trial which is available in the U.S. but not here, many of us know a lot of the U.S. kidney cancer experts which usually run these trials. So there's certainly a way to facilitate for a patient to be seen in those institutions. There's a number of things, however, to be considered. Number one if you participate in a trial in the US or elsewhere in Canada, you have to be treated at that center, which means if you go to the US or if you go to another part of Canada, you probably have to stay there and live there for the period of the trial duration. And that is often a logistically challenge. If you go out of the country, there can also be quite significant costs associated with it. If you go on a clinical trial, the treatment itself is usually free, but support for living there and for certain tests outside of the clinical trial, it may not. So those are things you need to consider if you really want to do that.
Just an open word is that most of the cancer centers offer multiple trials. So we do offer most of the trials that are available in the States. We have, and I know our cancer center and also Dr. Kollmannsberger's cancer center, lots of first line, second line, and third line trials. So lots of options available for patients at the cancer centers. I would encourage you to look at a trial because many of these drugs are very promising and a good opportunity to access these new medication.
Thank you. Another question. I have 2 mets in my lungs, but I'm not on any treatment. Is this usual? I had a radical nephrectomy in 2012. Mets were discovered in my lungs in May of this year.
So it depends. It depends on what's happening with those tumors in the lung. Again, if they're not changing much, I would encourage you just to keep an eye on them. Or even consider, if you have access, the option of burning them off or having them removed. If they're stable, I would probably just keep an eye on them, and if they progress, then you have options of drug therapy.
How do I know if my tumor is aggressive?
Well, the way you know your tumor is aggressive is, as we talked about at the very beginning, is what's called the stage and the grade. The grade is important, and these are the aggressiveness of the cells. They're rated according to what's called a Fuhrman's grade, 1, 2, 3, and 4. 1 and 2 are less aggressive. 3 and 4 tend to be more aggressive, and a higher chance of the tumor coming back. And the stage is also important. If there are larger tumors, then there is a higher chance of there being some micrometastases or a risk of spread in the future, usually T3 or T4. What that means is that the tumor has grown into the renal vein or the vena cava or into the organs around the kidney.
This from Leslie. My last CT scan 2 weeks ago showed no evidence of disease. I had 10 radiation treatments in July. I have been on sunitinib since my Whipple and metastatic diagnosis. Would you recommend continuing with Sutent as an adjuvant treatment or discontinue with Sutent?
That is an interesting question. Again, there's limited experience with this because sunitinib was also developed as a drug patients should stay on for as long as they benefit. Now, I think most experts in Canada, if you get to a point where all of your tumors are removed and you are in what we call a complete remission, most experts in Canada would probably at some point stop the sunitinib and just watch, simply because there is very little evidence or don't know whether sunitinib really still does something good if you get to this fabulous outcome. And second, most patients do have side effects which over time impact their quality of life. And from all we know is if we stop sunitinib in a situation like that and the tumor indeed comes back and grows again, then re-exposure to sunitinib seems to be a very good way, and there's a high likelihood that the tumor will respond to sunitinib again. This is at least what I do with my patients in that situation. I usually take them off and watch them.
I agree. That's what we do too.
Well, that's the end of the questions, the time that we have for questions today. But any unanswered questions, we will forward them to our panelists tonight. And you can find the answer to those questions and any other questions you may have at kidneycancercanada.ca. Just go to the Ask the Expert section of our website, and you'll already see questions that Dr. Kapoor and Dr. Kollmannsberger have answered from that people send in to us at info@kidneycancercanada.ca. So we'll give you that a little bit later. I want to remind you that tonight's webinar is going to be posted online, so you can have a look at it again and review the questions and the information that you were given. I'll tell you a little bit more about an information package that we will have for you. You can also watch past meetings, which is very helpful because we have a number of clinicians from across the country, so have a look at those. So that free information can be downloaded now. It's called Kidney Cancer Webinar, located under the Handouts section. It will also give you information on how you can help us advocate for additional therapy. Take our survey. We're running a survey right now that we are going to use when we make our recommendation that cabozantinib should be added to the schedule of drugs across the country. It's very important that we have this survey filled out. It's only going to take you a few minutes. You do not have to be on cabozantinib. It can be on any drug where there's active surveillance, but we do need your opinions. It's a really strong tool that we can use. Also, we invite you to attend our next webinar on October the 25th. Louise El Godbo is going to be joining us. She's a pharmacist, and we're going to be talking about the various kinds of drugs, drug interactions, and side effect management. So that is on October 25th. The registration is available. And also, if you are in Vancouver, British Columbia, join us, and Dr. Kollmannsberger will be there for our in-person meeting, November 23rd. It's completely free. We'll have light refreshments and snacks available, free parking as well. And if you don't live in Vancouver or British Columbia, maybe consider coming out and having a visit to BC, because it certainly is going to be a very interesting section. We're going to have researchers there. We're going to talk about some really groundbreaking research that's going on in Vancouver right now. And you also, we ask you to please sign up to be a volunteer and a community ambassador. That's really, really important for us because we need more engagement across the country. So before you go, please don't hang up yet. We'd like to ask you a couple of questions about our presentation tonight. So we're going to have the questions come up on the screen for you right now. Question one, how would you rate the information in this session, this webinar tonight? Very poor, poor, average, good, or very good? If you could respond to that question, that'll be a huge help for us. We can then determine how the webinar was for you, information that we could give you. And of course, if you have any comments, I'll put our email up at the end of the presentation, and you can definitely sign up for that. Okay, and we will just go to the next slide, and our next one is about next question coming up. What did you feel about the length of this webinar? Was it just right, too short, or too long? Okay, next question for you. We didn't get everyone responding there, so maybe we'll just leave the poll up for a little bit longer. And did you find this webinar convenient to attend? Yes, no, or you're not sure? And we'll just make sure we get leave that up for as long as we can so people can respond. Was it convenient for you? And if it wasn't convenient for you, and there's a couple of people or one person has said no, could you do us a favor and just send us your feedback? I'll again have the email up at the end, so that's terrific. And then we have, I think, just one more question for you. It's coming up on the screen right now. And that is, would you attend another webinar? Yes, no, or you're undecided. We'll leave that up for a bit for you. Well, that's great. We're getting a really good response on that. Most of you are saying, yes, you would love to come back. I really appreciate that. And what we're going to try and do over the next few months is schedule different topics, different clinicians. By the way, I should mention that our next webinar on drug interactions and side effect management will be in French and English. We're going to do one in French, and then we're going to do one in English. Okay? And just a final question for you tonight. We'd like to know how you found out about today's webinar. Was it through our newsletter? Was it through the Kidney Cancer Canada website? Was it through social media? Or was it from a family or friend or a healthcare professional? Who told you about where this information came from? Because that will help us speak to you a little bit later. Just those votes are still coming in. And this actually helps us communicate with you, because one of the things we want to do is find out what's the most appropriate way to talk to you. Is it through the newsletter? Is it through our website? Or should we put it on social media? And for those of you that are actually identifying as a family or friend, please consider going to our website at kidneycancercanada.ca and joining our community. It doesn't cost anything. We send you lots of information, and if you haven't signed up for our newsletter, please do, because that well, that's it for tonight. Thank you very much for joining us, and I want to thank Dr. Kapoor in Hamilton. Thank you, Dr. Kapoor, for participating in this first test, and Dr. Kollmannsberger in Vancouver. It's nice to be across the country, and to you, Hélène, in Quebec, thank you very much for joining us. I think it was a great success. The feedback has been really popular, and of course, at any time, if you, the people attending our session tonight, want to get in touch with us, I'll leave this slide up on the screen for about 5 minutes afterwards, and our number. And again, if you have any questions for the doctors, if you have any questions, period, that you need answer, please contact us. And my team of Mona Awad, who is in Quebec, or Jan Coleman, who is in Ontario, they will forward those on, and we'll make sure. I talk to Dr. Kollmannsberger and Dr. Kapoor pretty frequently, as well as other clinicians. We will get you an answer, and we will post them on the website, because we know it is quite an anxious time. Certainly was for me when I was first diagnosed, and we are here to help you. So please remember that. So thank you, everybody. I really appreciate your time. We've gone 7 minutes over, but this was a very worthwhile hour and 37 minutes. And hopefully we will see you all again on October the 25th, our next session. Good night.
Thank you very much.
Thank you. Stephen, one last question. Can you have a poll about who's more handsome, me or Dr. Kollmannsberger?
You seriously want to ask that question?
Have a good night, guys. Thanks so much. It was a lot of fun.
I think the dog would win, Dr.
Thank you very much.
That's probably true. That's probably true.
Good night, everyone. Good night, everybody.
Good night, guys.
Good night.
Take care.
Good night.